Hey everybody, welcome to our Facebook Live Tele-NICU Simulation. We're broadcasting today from Health Alliance Clinton Hospital in Leominster, Massachusetts. My name is Dave Smith. I'm the Associate VP of Virtual Medicine at UMass Memorial Health Care. You might be asking yourself, what the heck is virtual medicine anyway? It's really just a fancy term for describing the remote delivery of healthcare services using communication tools like the internet or smartphones or tablets. Basically, everyday devices that most of us have or have access to. Sometimes we refer to this as telemedicine, other times we call it telehealth. Whatever you want to call it, we feel that it's the future of healthcare. And so we are investing in new programs and new services to extend our expert care to you, our patients, wherever you may be. Now, telemedicine is not a new concept to UMass Memorial. In fact, we've been delivering virtual care in one form or another for the better part of 15 years. Our programs like EICU and Telestroke have delivered thousands of virtual consults over the years. In fact, you may even know somebody who has benefited from one of these services. But these programs generally depend on expensive and very sophisticated technology solutions. And we believe virtual medicine should be available to anyone. And so we're building a platform based on everyday technology like web browsers and smartphone apps so that you can interact with your doctor from the comfort of your own home or wherever you may be with the push of a button. And that really gives you the choice as to when, where, and how you receive healthcare services from your UMass Memorial provider. Now on to today's topic, Tele-NICU. I think this is a great program because it serves one of our most vulnerable populations, which is premature or preterm infants. And let's be honest, who doesn't like helping babies, right? Our UMass NICU is the region's only level 3 neonatal intensive care unit. And so that means we have the experience and the expertise to care for the sickest babies when they need our help. But sometimes our doctors aren't where the babies need them to be. And that's why Tele-NICU is so great in bringing that expert care virtually within moments to the baby's bedside to assist them through the first few precious moments of their life. So before I introduce our star of the show, I just want to remind folks that if you want to submit questions, please use the comments section of the Facebook Live page. If you're bashful and you want to submit them via Messenger, we'll be monitoring that through the simulation as well. Once the sim is complete, then we'll have a Q&A session where we'll answer any questions you may have about the program or any other questions around UMass Memorial Virtual Medicine Services. So with that, it is my great pleasure to introduce Dr. Javed Mannan to tell you a little bit more about this innovative new program.
Thank you, David, so much for that great introduction. As David said, I'm one of the neonatologists and the director of neonatal outreach at UMass Memorial Medical Center. As the rates of preterm infants have been increasing over the last few years, there's been an increasing demand for expertise in neonatal resuscitation. Since these infants are often quite sick and it's unpredictable where they will be delivered, we see that even in community hospitals, these high-risk infants continue to be born, and often these hospitals are not set up to deal with such critical and fragile infants. We know that some of these factors will often even lead to worse outcomes for these preterm infants if they're born in these community hospitals. Today, we plan to perform a simulation that will demonstrate how telemedicine can be used to connect community providers with instant access to expert neonatal care. And our players today will be, our community provider will be Christine Tingley, a neonatal nurse practitioner here at Health Alliance, and she'll be connecting with one of our neonatologists, Dr. Sanjay Arora, back at UMass Memorial Medical Center. We'd love to hear your thoughts, feedbacks, and questions. So as Dave said, please feel free to post your questions, and we will go over these questions at the end of the simulation. Once again, we'd like to thank everybody for tuning in today, and we'd love to now go forward with our simulation.
Hey guys, can you call the code white? Linda, I'm going to have you turn the warmer on. Thanks, Amy. I'm Christine. I'm one of the nurse practitioners tonight. I'm going to have you call UMass, and if you can alert the telemedicine system, that'd be great. Let's put the pulse ox on. Perfect. And get me a heart rate, okay? Want to turn the neopuff on too? I think if you grab the mask, it'll be okay. She can get it. Just give me a heart rate. When the supervisor shows up, can you just have her start documenting? Sure. Thank you. And then a respiratory therapy will be part of the code white, so they should show up as well. Okay. Respiratory? How are we doing?
65.
60? 65? Okay, good. Let's get the neopuff on. and when respiratory gets here, we can have them start for us.
I'm here now.
Here you go. I'm gonna have you come on this side, and Amy, you can go there too. Hi, Dr. Aurora, can you see us? I'm gonna have you come on the other side, Jason.
Hi, Ms. Bingley. Yes, this is Dr. Sanjay, Medical Director of NICU at UMass. How can I help you?
So I have a baby that's unknown gestation, came in delivered quickly. We know that the prenatal labs are negative, but baby's not really breathing. We have the baby on a CPAP of 5, irregular respirations. The FiO2 is about 30. The pulse ox is picking up now. The heart rate's about 65. The saturations are 50. We're in 30%.
Yes, I agree with you that the baby's not moving much air. Let's add some positive pressure ventilation. Let's go up on the oxygen to about 60%
Okay.
and see how we do.
Sure.
60%.
Jason, can you see the neopuff?
I can, yes.
Okay, good. He's got about 25/5 and a rate of 25 on the neopuff right now. And we turned the
Yeah,
FiO2
that
up to
sounds good.
60.
Yeah, 25/5, 60% sounds good.
Can you get me some
And
information supplies?
let's see how the baby moves.
So
The
I'm gonna
rate
steal
is
this
still
paper.
60?
Yeah, the heart rate is 65 still, but the respirations, baby's really not moving any air.
So I think you may need to move towards intubation.
Okay, we're gonna pull supplies out.
Yeah, so make sure you get a suction catheter ready. Make sure you get a 3.5.
Baby's about 3 kilos and probably about 6 weeks early.
So yeah, I would go for a 302 to start off with and 9 centimeters depth of insertion.
Okay, we're gonna intubate now. And I'll have them put the capno. I need the capnometer. You got it right there. Okay. Can you just give me a little pressure right there, Jason? Thanks. Okay. You said about 9?
Awesome.
About 9, right? There you go.
Yeah.
Can you put the capnometer on? Oh, perfect. So we're getting color change. Give her a couple puffs.
Great, excellent. I see that you have misting and you got the color change, so you guys are doing great.
Chest rise too.
And-
Can you go with the tape? Thank you.
Now, how's the baby doing?
So on the pulse oximeter, thank you so much. Still, we're below 60 now, and SpO2 is pretty good in the 89, but the heart rate isn't coming up.
Okay, what's the heart rate now?
It's 48.
Up on the warmer. On
Okay,
the.
I think we need to do some chest compressions.
There you go. Okay, chest compressions are started. I'm gonna start. That's okay, don't worry about it. Jason's holding it. So they're giving chest compressions. We're opening the lines up.
Great, get a UVC ready for epinephrine. You need to get 1 ml per kilo.
One ml per
Get that
kilo.
And 1 ml per kilo down the endotracheal tube. Get that ready if you're not able to bring the heart rate up.
Okay, we'll do that first then while I'm getting the lines ready.
Great, thank
Okay.
you.
Yeah, you can put 3 mLs down the ET tube. Can I just have a 5-0 line? I think they're in here. Yeah. I'm gonna come in behind
Good
you.
job compressing. I see the ratio is going well, 3-to-1, so you're doing well with coordination. And make sure the epinephrine is 1 to 10,000, please.
Okay. Epi 1 to 10,000, we have 3 mL.
Can you see that?
Yes, great, excellent.
Okay, that's
Thank
going
you.
in now.
Epi's in.
Excellent.
I just need some sterile gloves.
All right.
I'm gonna put the line in now. Heart rate's still low, so we're gonna put the line right in.
Yep. And just put it until you get flashback. You may want to get some normal saline ready. I would get 10 ml per kilo, which is 30 ml of normal saline, which the baby could probably benefit from.
Okay, Amy's pulling that up right now.
Great.
I'm gonna. Thank you.
Excellent teamwork out there, guys.
Thank you. Do you want us to pull up the epi for when I get this line in if we need it?
Yeah, so the dose is lower through the UV. You get 0.1 to 0.3 ml per kilo.
Can you pull that up so I need to prepare? Thank you.
30 mils of normal saline ready.
So that's 0.9 ml, 1 to 10,000 epinephrine.
Okay, they're pulling that up now.
Okay.
0.9.
Yeah.
0.9 of epi ready.
Great.
And I'm just gonna, and I'll have you come over with the saline after too.
Sure.
Okay, I'm getting blood return at about 7.
Great, that's fine.
Okay.
I would give 30 ml of normal saline bolus, please.
You can hook up right here. Do you want us to put the epi in first or the bolus?
I would put the bolus
Okay,
next.
right there. Go ahead. Okay, the bolus is going in. Hang on, let me just move this. Bolus is going in, and I'm gonna hook the epi up for when it's done.
Yeah. Alright, how's the heart rate doing?
We have a stat that's gone up. I have it on here. It's up to 85, and now the heart rate's up to 120.
Okay, so you can stop compressions, please.
Okay, and we flushed the
And I'll
line.
continue the positive pressure ventilations. Flushing the line is great.
We flushed the line, and the epi and the bolus are all the way in. Jason's still giving 25/5 and a rate of about 25. Oxygenation's come up.
Yeah, the ambulance was called and so your team should be arriving shortly.
I think they just came in the door.
Oh, that's amazing. Great. Awesome.
I think we're
Thank
stable
you.
for now. We can have them call you back before they leave.
Remarkable job. Good work, team. Please feel free to call us back if you have any questions. Thank you so much.
Thanks for being there.
Alright, bye for now.
Perfect.
Great, thank you guys. So that was our resuscitation. As you can see, Dr. Sanjay Arora from a distant site at UMass Memorial NICU was able to help the resuscitation team here and help them guide through that. So that's our plan. Anytime there's a sick baby, anytime there's any kinds of questions or consults, our plan is to have the team at the hospital call us at the UMass NICU. We're always there 24/7, 7 days a week, and so we're always here to assist with the team with any ways they would need at any point at any time. So we hope that this has been helpful, and we hope that we were able to demonstrate how telemedicine may be used to help infants in the community hospitals. Thank you guys. So now we're going to take some questions and answers.
So we did get some questions come through on Messenger during the simulation. I'm just going to take them in the order that they came in. First one, why use a computer when you can see a doctor in person? Actually, that's a fantastic question. So I would liken that to why do we do online shopping? Why do we love Amazon so much? Because it's convenient and it generates a great positive customer experience. Another reason is some of our patients have transport needs. They don't have transportation to get to and from the doctor. So that might be another reason why. And I think the last is probably just from a time-saving perspective. I think the average office visit, total time between driving to and from the doctor's office, parking, sitting in the waiting room, getting the exam, is like an hour and 50 minutes, almost 2 hours of a patient's time, whereas a typical virtual medicine visit can be done within 15 minutes. Next question. What other telehealth, two-part, what other telehealth programs are available? So I mentioned EICU and telestroke. Those are two of our biggest programs today. We also do teledermatology, a lot with telepsychiatry, particularly around substance abuse counseling. There's such a demand for access to those types of services that it's a great application for telemedicine. We do inpatient specialty consults, and of course, we're in the process right now of expanding a lot of our programs to be more directly engaged with the patient themselves. So virtual visits with your primary care physician is coming soon. The second part of that is what is the future of telehealth at UMass Memorial? Well, I think the future is really when we start, or we stop, I should say, distinguishing telemedicine as something different and unique. And it really just becomes part of how we deliver care, and it's just another tool in the provider's toolkit. Dr. Mannan, here's one for you. I live in Leominster and will be having my baby at Health Alliance in November. Oh, congratulations. Is this something that will be available to my baby if she needs it? I'm having a girl.
Yeah, so that's a great question. Congratulations on having a girl. As you said, anytime there's any concerns, either whether it's emergent, urgent deliveries, or even questions or consults, our UMass NICU team is always available at any point in time. And what we want is that this telemedicine card will be available in all our community hospitals at any point for the providers here to connect with us so that we can visually see what's going on with these infants. So yes, we will be able to infiltrate this system and start using it, and they can use it for any type of purposes that they would need and any type of guidance or assistance they would need, and we'd be happy to help them in any type of way, because our goal is to keep mom and baby together. That is our ultimate goal. But obviously we know that some babies, they're going to be sick and they're going to need to be transferred to a higher center, and that's why we're here. We're trying to improve those outcomes, because really we know the first minute is really crucial for the long-term outcomes of these babies, and that's what we really want to do. We know that the doctors here are great, but we're limited by what we have in our community hospitals. And even us as neonatologists, we can't be in every single hospital. We have to cover our own hospitals. So this is the best way to kind of be available, almost essentially if we were in the delivery room in front of that baby without actually having to be there. So I think this is a great kind of leeway. So we hopefully plan to be up and running very shortly, so that we can assist all of our community hospitals.
One last question. Hi, I'm a patient at UMass Memorial. Thank you. And I'm wondering if I will be able to use this technology with my primary care doctor. Another great question. It's coming soon. We are working very hard on expanding access to all of our providers using virtual medicine solutions. We're in the process of integrating